This module gives an overview of the various approaches to the central venous catheter insertion procedure. Stop! Before we can discuss the details of the procedure, you must perform a timeout. A timeout is the Joint Commission's requirement that ensures that you have the right patient getting the right procedure on the correct side. This requirement may prevent adverse events and must be documented in the chart. The ability to reduce central venous catheter infections and complications begins with proper pre-procedure hygiene and preparation. Strict sterile technique has been proven to reduce central line-associated infections. This includes use of a sterile gown, gloves, mask, hat, a full sterile body drape that covers the patient head to toe, and appropriate sterile draping of the ultrasound. The skin site should be cleaned with chlorhexidine scrubbing in a back and forth motion in accordance with manufacturer's guidelines. The insertion site should be marked once identified. Marking may be more relevant for the subclavian site because once the patient is draped, anatomic landmarks are more difficult to identify. It is less relevant when you're using an ultrasound because of the live imaging. If sterile saline for flush is not present in the central line kit, please be sure to draw up saline for injection or find some sterile preloaded syringes with injectable saline. Keeping an open bowl of sterile saline on the field is not appropriate due to particulates in the air that may settle into the fluid. Make sure you flush all of the ports and needleless connectors to remove air. Please note that the guide wire exits through the distal port. Using a sterile ultrasound probe cover, drape the ultrasound. The patient should be put in slight Trendelenburg position to prevent air embolism. With ultrasound guidance, there are two planes of imaging used to introduce the needle, the short axis and the long axis. I recommend the short axis view because the long axis requires a higher level of experience to ensure the needle is visualized in the proper plane. The triangle technique was developed to make cannulating the vessel easier without having to find the needle tip on the ultrasound screen. It can be very difficult for beginning users to understand how to look for their needle tip on the ultrasound screen because there is a lot of acoustic shadowing from the needle tip. Because of the shadowing, it may be impossible to determine if the needle is poking through the bottom of the vessel. The triangle technique was developed to prevent this from happening. Using the triangle technique, use the ultrasound image and probe only to align your needle. It is not necessary to watch the ultrasound screen to see if your needle is in the proper location. Instead, watch the syringe for a flash of blood as you aspirate. Placing the ultrasound probe on the skin above the vein, measure the distance from the top of the skin to the middle of the vein. We'll call this distance X as seen on the slide. If you look at the ultrasound machine, you can identify the distance in centimeters using the gridded hash marks on the right of the screen. Using simple geometry, we know that if the needle is inserted at the same X distance back from the center of the probe and enters the skin at a 45-degree angle, the vein will be entered right in the center as the needle is advanced. It is key that the needle is centered directly on the ultrasound probe. The use of ultrasound guidance has been most validated for internal jugular vein insertion. Studies show a higher incidence of successful placement and lower carotid punctures, number of attempts, and access time. Ultrasound guidance also reduces mechanical complications from femoral line insertions. However, data on ultrasound-guided subclavian insertions are mixed. In the picture, the clinician is scanning the internal jugular vein using the short axis view. The video shows how the vein can be identified. The vein is easily compressed while the artery is not. In this picture, the clinician is cannulating the internal jugular vein using the long axis. The video shows the needle coming in at the top of the screen. Ultrasound likely reduces complications from internal jugular and femoral vein insertions because of significant variation in the location of these veins in relation to their corresponding artery. For instance, the relationship between the internal jugular vein and carotid artery varies widely from patient to patient. In up to 9% of patients, the artery is superficial to the vein, and in 18% of cases, the vein is not visible or is thrombosed. Now let's get back to the procedure. There are two methods to cannulate the central vein: the catheter over the needle technique, otherwise known as the modified Seldinger technique, or actually using the needle itself, the Seldinger technique. With the modified Seldinger technique, please ensure that after cannulating the vein, you advance the catheter over the needle to make sure that the catheter is all the way to its hub. Remove the syringe and needle and advance the guide wire through the catheter. Please note that the needle that is inserted into the catheter does not have a large enough bore to accommodate the guide wire. The modified Seldinger technique makes it easier to transduce a pressure and to cannulate smaller vessels. With the Seldinger technique, stabilize the needle in the vessel. Remove the syringe and advance the guide wire through the needle. Be sure to use what I call a C-clamp to ensure the needle doesn't move during guide wire placement. The C-clamp is a formation with the index finger and thumb holding the needle hub and the rest of the fingers wrapping around the needle and anchoring on the skin. In both Seldinger and modified Seldinger, the free thumb can be used to block the lumen of the catheter or needle so air cannot enter into the vein. When advancing the guide wire, please remember that the distance from the point of entry to the right atrial caval junction averages 15 centimeters. Therefore, if more than 15 centimeters of the guide wire is advanced, you incur the risk of tickling the atrium or the ventricle or even going down into the inferior vena cava. Certainly, this is an issue if the patient has an inferior vena caval filter, so please be mindful of how much guide wire is actually going into the patient. Most guide wires have markings. For instance, one black mark will indicate 10 centimeters of distance, while two black marks will indicate 20 centimeters of distance, and three black marks will indicate 30 centimeters of distance, and so forth. Once the guide wire is in, remove the needle or catheter and nick the skin with the scalpel. Dilate the tissue tract into the vessel. The entire dilator does not need to enter the skin, but with a twisting motion, advance the dilator until there is a change in resistance indicating you have dilated to the vessel. Please be sure to advance the catheter over the wire. Don't advance them together. Again, you do not want too much wire in the patient because this can cause guide wire embolism. Make sure that all ports are locked or capped so that air cannot get into the system. Aspirate and flush each port with normal saline. Take care not to pull blood all the way back into the needleless connectors or caps because some types require significant flushing to clear them of blood. Place a sterile dressing over the site per hospital policy. Obtain a portable chest X-ray after placement to ensure that there is no pneumothorax and that the line is in the proper location at the atrial caval junction. Remember, if you're not at the junction, it is not prudent to advance the line further if it is already in an acceptable place due to the increased risk of infection. It is more appropriate if the line is too far to pull it back. Now, let's specifically talk about the various approaches to central venous catheter insertion, starting with the internal jugular vein. Assuming that an ultrasound is not present, there are three different approaches using anatomic landmarks: the median, the posterior, and the anterior approach. I recommend the median approach. However, ultrasound guidance has become the standard of care. If there is an ultrasound available, this should be used rather than using anatomic landmarks. In the median approach, the needle is inserted at a 30 to 60 degree angle with the skin at the junction of the two heads of the sternocleidomastoid muscle. This is the sternal and clavicular heads where they form the triangle. The needle should be pointed towards the ipsilateral nipple. If you are using the ultrasound device, it is not necessary to try to point towards the ipsilateral nipple because the ultrasound guides you as to the direction of your needle. Given the fact that most of the time an ultrasound should be available, I am not going to go into detail with the other approaches at this time. There are many advantages to the internal jugular approach. First, Remember that the vessels are compressible, so if the carotid artery is accidentally punctured, direct compression will usually achieve hemostasis. Second, the right internal jugular is a direct path to the right atrium. Therefore, in the event that you need to do pulmonary artery catheter monitoring, this is the site of choice. Third, the internal jugular has a lower deep vein thrombosis risk than the femoral vein site. Remember, however, that many authors still favor the subclavian site for reduction in deep vein thrombosis risk. Fourth, there is a lower risk of pneumothorax than the subclavian site. And finally, there is good evidence to support the use of ultrasound guidance for internal jugular vein insertion, whereas for the subclavian site, the data are mixed. What are the disadvantages of the internal jugular approach? Well, certainly, you can cannulate the carotid artery in air. Please remember, using the ultrasound in a proper way should prevent this complication. This complication is more serious in elderly patients that may have plaque buildup in their carotid arteries. Also, please take into consideration that the internal jugular site is not a good place to put in a line in a patient that is mobile for obvious reasons. Left internal jugular vein insertions are also associated with the potential for thoracic duct injury. Additionally, it may be a relative contraindication to place an internal jugular line in patients that have increased intracranial pressure. This is more controversial. However, please keep in mind that it is the internal jugular vein that is responsible for the venous return from the brain. Finally, please consider that in patients that have tracheostomies or those who are on a ventilator, that their secretions are in close proximity to the site of entry of the line. Therefore, internal jugular lines may be harder to keep clean and the infection rate is higher than some other sites, such as the subclavian. Let's move on to subclavian lines. A main difference in inserting a subclavian line is that you really need to take care in anesthetizing the periosteum of the clavicle. This is because you're using the clavicle as your point of entry to the vein and you will be marching down the clavicle with your finder needle until you get into the vein. For the approach of the subclavian site, remember to point your needle towards the suprasternal notch. The needle should be parallel to no more than a 15-degree angle to the skin or ground. Please be sure that the needle bevel is not pointing towards the head. If the bevel points towards the head, the non-sharp point of the needle can hit the vessel first and cause shearing. When inserting the guide wire, please ensure that the J-point of the guide wire is pointing towards the patient's feet. This makes it more likely that the guide wire will go down the superior vena cava towards the right atrial junction. There are essentially three approaches to the subclavian line that are described in the literature: the median, the lateral, and the middle approach. I particularly don't like this sort of classification with subclavian lines because I think it's more appropriate to enter the patient's skin where there is a natural bend in the clavicle downwards and where the needle can safely be placed into the skin at a 0 to 15-degree angle to direct towards the suprasternal notch. As for ultrasound guidance of subclavian lines, the data are mixed. Some studies show a benefit and some do not. Please keep in mind that the subclavian vein is under the clavicle, so ultrasound imaging of the subclavian vein can give significant acoustic shadowing to the point where the vein cannot be visualized. Clinicians that typically use ultrasound for subclavian vein cannulation are often visualizing the vein with the ultrasound in an extrathoracic location. Here is a graphic depiction of a needle cannulating the subclavian vein. Please note that it appears the needle is going in at approximately the bend of the clavicle toward the sternal notch. The needle tip should be hitting the clavicle at approximately the lateral edge of the clavicular head of the sternocleidomastoid at no more than a 0 to 15-degree angle to the skin and about 1 centimeter inferior or caudal to the clavicle. Simply put, right-sided lines should be inserted at an average of 14 to 16 centimeters, and left-sided lines should be inserted at an average of 16 to 18 centimeters. Remember that no patient is a textbook and that all patients come in different sizes, so memorizing one distance for any particular patient may not be correct for another. One study evaluated the use of a formula for calculating the distance of line insertion. Height is measured in centimeters. In this example, a 6-foot patient would have their right internal jugular line inserted to 18 centimeters. However, this may be slightly long in some patients. Consider measuring the catheter over the chest because exact insertion location within the muscular triangle of the neck may affect the accuracy of this formula. There are distinct advantages to the subclavian approach. The subclavian vein does not collapse in hypovolemic shock, whereas the internal jugular may be more collapsed or compressed. There are lower rates of infections of the subclavian site than both femoral or internal jugular veins. Also, there may be a lower risk of deep vein thrombosis. If a patient is ambulatory, the subclavian line is much more comfortable. The landmarks are very easily identified in a case where an ultrasound is not available. However, with the advent of ultrasound-guided internal jugular insertions, there are not significant data comparing subclavian lines to use of ultrasound at other sites. Certainly, disadvantages to the subclavian site prevent a lot of clinicians from using this approach to central venous catheter insertion. The vessels are not compressible, so the risk of bleeding is highest. There is an increased incidence of pneumothorax, and this site needs to be avoided in patients with both end-stage renal disease or in patients on their way to being on dialysis. Additionally, patients that have had multiple prior upper extremity lines tend to develop stenosis in the subclavian vein. Furthermore, I find that many clinicians are more comfortable cannulating a vessel they can directly visualize with the ultrasound. I want to briefly touch on femoral line insertion. Remember that femoral lines should be a last resort when either internal jugular or subclavian sites cannot be used. Also remember, although femoral lines may be easy to place, due to complications and time requirements, the American Heart Association recommends that during a cardiac arrest situation, a peripheral IV or intraosseous line be used during resuscitation efforts. When placing a femoral line, remember the anatomy mnemonic: navel, nerve, artery, vein, and lymph nodes, where the lymph nodes are closest to the midline. The needle entry point is 1 centimeter medial to the femoral artery and about 1 to 3 centimeters inferior to the inguinal ligament. Ultrasound guidance has been shown to be an effective and safer, more successful way to insert femoral lines. There are very few advantages to inserting femoral lines over other sites. They are easily placed. There is also no risk of pneumothorax. Many clinicians place femoral lines during cardiac arrest because the vein is easy to access. Again, this is only appropriate if peripheral IV access and intraosseous lines are not available. However, femoral lines should be avoided for several reasons. These lines are associated with the highest infection rate. Despite more recent evidence questioning the high infection risk associated with this line, the Center for Disease Control guidelines still recommend avoidance of the femoral site to prevent central line-associated infections. Femoral lines are also associated with the highest rate of deep vein thrombosis, and you cannot do reliable invasive monitoring through them. If a femoral line happens to be inserted, remove this line as soon as possible, ideally within 24 to 48 hours. Here is a graphic depiction of the right leg and the femoral anatomy. There are varying degrees of overlap between the artery and vein, likely explaining why ultrasound technique prevents complications. Now let's talk about another real-life patient. The patient was a 46-year-old male with a right-sided pneumonia. He had severe sepsis and was admitted to the medical ICU. Because the pneumonia was on the right side, a right-sided subclavian line was inserted. After the guide wire was placed, the patient started complaining of ringing in his right ear. The line insertion was completed and the patient continued to complain of ringing. A chest x-ray was performed, which confirmed the line was in the right subclavian vein, but then curved straight up into the right internal jugular vein. Several points need to be made from this case. First, ringing in the ear can be a sign of the line going up to the ipsilateral or contralateral internal jugular vein during subclavian line insertions. Second, there are not well-studied strategies to prevent malpositioning from occurring short of using fluoroscopy during insertion to ensure the guide wire follows the correct path. However, one randomized clinical study showed that if the J-point of the guide wire is pointed towards the feet of the patient, then the guide wire is more likely to follow a path toward the atriocaval junction. And third, this line cannot be safely adjusted without increasing the risk of infection. Changing over a guide wire can introduce pathways for contamination of the line. Pulling the line back and re-advancing produces the same concerns. In the next module, we will discuss common complications that arise from central venous catheter insertion and prevention measures.